good evening to everybody. They are attending our meeting today. It is my pleasure to be with you all here again after Eid. After I think maybe 4 weeks, we just stopped during Ramadan and Eid our meetings. And today we are going to have a very interesting and interactive sessions and in a new way to deal and to expose or to present the topics with discussions. And I'm really, I feel proud that we are having a very eminent speakers from worldwide. I have my dear friends, Dr. Carlos Matthew, Dr. Ahmed Al-Khashab, Dr. Faisal Fayyad, and Dr. Stratos, and Dr. Grazia Bertilli. So I would like to welcome all of you. It's nice to be with us here today. And I would like, if you also a new way that I will leave 1 minute for everyone just to give a brief about himself and introduce himself. So it will be more better by his mouth that we are hearing what he want to say. I will start with yes, this is a very nice way, Dr. Faisal Fayyad. So you prepare. I know most of you well-known figures in the world, but also it's better to have some information. I will start with Carlos.
Well, thank you, Mohammed, for organizing this with this kind of, impressive surgeons. My name is Carlos Mateo. I live and work in Barcelona, and now Barcelona and Madrid. And, I'm really enthusiastic, sharing with my friends, 1 hour and a half or something like this to discussing cases. Next it will be, whatever you, Grazia, present yourself. Introduce yourself.
So I think you didn't finalize. I think Dr. Carlos, one of the pioneer in vitreoretinal surgeon, and he is well known and he is having many things. So this is what I want to hear from you, Dr. Carlos. Anyway, let's move to Dr. Grazia or Dr. Faisal. Anyone just with them.
Grazia, please.
Grazia. Thank you very much for a kind invitation. It's really a pleasure to be with you and to share the opinion, my opinion, and to have a confrontation with you. I'm Italian and I work in Verona. And before working in Italy, coming back in Italy, I worked in Holland and in Belgium for a while. And I'm very happy to meet you virtual this evening, waiting for a live event.
Thank you, Dr. Grazia. Dr. Faisal?
Yeah, I am Faisal Fayyad from Amman, Jordan. I'm practicing at the Jordan Hospital, which is a very big private hospital in Amman. My main practice is in retina and vitreous. And actually, I should have thanked everyone before, giving this my short CV of mine. Thank you, Carlos, for your kind invitation, and Mohammed for your kind invitation as well. Thank you, guys, and I hope to see you soon in real life.
Thank you, Dr. Faisal, but also I want to mention things that Dr. Faisal, one who has established the vitreoretinal surgery in Jordan, and I am proud that I work maybe a very few times with him and learn from him a lot when I was doing my residency program. Even Dr. Faisal is not an old, he is just a young man. Let's move to Dr. Stratos.
Good evening, everybody. I'm Stratos Gotzaridis. I'm based in Athens. This year, I conclude 20 years in private practice. I did my training in Moorfields in vitreoretinal surgery long time ago with Sven Gregor, which I'm proud of having him as a teacher. And then I moved to Boston 1 year with Don D'Amico, and then came back to Athens. I'm doing VR surgery. I'm delighted to be with you tonight, and I'm sure that I have more to learn than to present. Thank you to Carlos, and thank you to you and to everybody who were involved to organize this webinar.
Thank you, Dr. Stratos. My dear friend, Dr. Ahmed Al-Khashab.
Thanks a lot, Mohammed, for the kind invitation, and thank you, Dr. Carlos, for having me with this eminent speakers and real mentors for vitreoretinal surgery from all over the world. I'm Ahmed Al-Khashab. I'm from Egypt, a vitreoretinal surgeon, but I'm based in Dubai. I'm working in Eye Consultant Center in Dubai Healthcare City, mainly vitreoretinal surgeon, but I'm covering as well some anterior segment as a part of the job, as all of you.
Thank you very much, Ahmed. Thank you for all of you. Now it's the time for Carlos. Yeah, please, if you want to share the presentation, and we can start. The mic with you, Dr. Carlos.
Okay, let's go. Thank you guys for coming, and it's my real pleasure to have you here. We are going to discuss some cases that we find in your daily practice. You know, there are many different cases. The doctors that our friends that are here has sent some videos, but you know, it's meant to discuss every single technique we are going to show. We're going to start with a very intriguing disease, you know, the optic disc pit. And my first question will be, there are two questions here. The first question is, do you apply different treatment or different strategy depending on the aspect of the retina? For example, in the first case, you see a foveal detachment. In the second case, you see a, you know, schisis. In the third case, you see a retinal detachment. And the second question is, there are plenty of options to treat a primary case, not to reoperate the case, but, you know, to a primary case. You have posterior hyaloid, dysplastic retina inside the pit, you have the laser, you have the inner fenestration, platelets, backling, you know, inserting scleral inside the pit or inverted ILM. Then, you know, the first case is going to be presented by Faisal Fayyad. He has shown, sent this patient. Faisal, this is a case of you want to introduce the case, and you tell me when I press the start.
Yeah, let's start, please. This is 19 years old boy. He came to see me with optic disc pit. As you can see there, this is how I started the case, by detaching the posterior hyaloid. And this is quite old case, as you can tell from the video itself. There is some posterior hyaloid still attached. And I was discussing with Stratos Goutsaridis the cases. He told me, well, peel the internal limiting membrane. I said, okay, I have to peel the internal limiting membrane because there was also the posterior hyaloid attached to the macula and there was no CME. In this case, I could have inverted the ILM inside the pit, but I did not. And you see it there. Surgery is finished, and I just injected some gas. You see the pit, and you see the case after ILM peeling. This is, and I asked the patient to stay in prone position for 2 to 3 days, trying to aspirate through the optic disc pit, the fluid, and more aspiration. And this is how it looks like before and after. It took a lot of time for the subretinal fluid to disappear. It took over a year for the subretinal fluid to disappear.
Okay. Any comment from the rest of you? Any comment, Grazia, Ahmed, Stratos? I have some comments but Stratos, you may, Faisal mentioned you about the ILM, and we are going to talk about it.
Well, my impression is that optic pits, there are more than the ones that create the foveal detachment. And the one that create foveal detachment is because there is a traction on the macula. And the traction of the macula creates a space where the pressure in that area is lower than the pressure into the vitreous cavity. Therefore, fluid travels from the central of the vitreous cavity through the optic pit underneath the macula. So once you destroy this traction and leave the macula, I initially did as Faisal used to do, as Faisal did, to place gas into the eye in order to push it, but it's not necessary. Just release the traction from the posterior vitreous and the ILM, and then the macula will gradually go back and will absorb that fluid, and takes a long time because the fluid becomes viscous. That's why it takes a long time, like the diabetic tractional detachment, where the subretinal fluid is viscous and needs time. This is what I'm going to do. This is what I'm doing in all my optic pit cases.
Great.
Posterior vitreous detachment, ILM peel, and that's it.
Okay.
And actually, I was preparing to present a case of 5-year-old boy, the youngest ever published patient, where I did exactly the same. ILM peel, PVD, and end of story. And the boy now, it's after 10 years, has a vision of 9/10.
Okay.
Yeah.
Grazia.
Carlos, yeah,
Go ahead.
I don't completely agree about ILM peeling in the macular area. What I usually try to do is a fovea sparing peeling only in the nasal part, because indeed it is true quite often there is obstruction and the retina is pulled inside the pit. But I don't like to peel the ILM over the fovea, for both reasons, because these patients are usually young, and we know that years later we see not a nice aspect of the inner retina. So if possible, I don't touch the foveal area concerning the ILM, and also because sometimes you have a kind of external macular hole. And due to the traction in the nasal part, you can end up with a macular hole, full thickness macular hole. So I prefer to leave the ILM around the macular area.
Ahmed, any comment? Any more comment?
I agree totally with Grazia. I would do exactly as Dr. Faisal did initially, but now I'm doing a foveal sparing, and I'm trying to invert the ILM in the optic pit itself. Just giving an extra closure point for this pit. And I agree totally. Usually it takes very long time for this fluid to be absorbed. I don't have a lot of cases, but at least in my hand, they would take about 5 to 6 months to be absorbed totally.
Okay, let's go for the second. Excuse me. Let's go for the second case. This is Faisal Fayyad. He's going to show something very special that I love it. You know, this is a tissue inside the optic disc pit. Faisal, this is your case. This is a very interesting case.
Yeah, 28 years old female patient. Can you start, please?
Sure.
And this is as a routine. I think this is 2009 I did it. And I'm showing this case because there was a negative pressure. There was that tissue going through the optic pit. In that space, you see it disappeared. Now I took it out of the optic disc. I take it out from the pit. There is CME, as you see there. And look at that. Look at that. What happens? There is negative pressure. It went inside, just like vacuum. And now I decided to remove this tissue from the optic disc pit. I went through the pit with this pointed forceps and remove it completely from inside the optic pit. See there? And since there was negative pressure, I decided to do laser on the temporal side of the disc in order, like a barrage, to make a scar. And actually, the patient did very well. This was, unfortunately, the OCT is not available. I changed my OCT a long time ago, and this was the Stratos from Zeiss at that time that I'm not using anymore, and the data disappeared. I thought that was a very interesting case to show because I never saw a negative pressure in the optic disc. This is just one more proof that the fluid really, I think, it comes from the vitreous cavity through the pit underneath the macular area. And that's the reason why I applied this endolaser here.
Great, great, Faisal. Let me show you my case just to say the same. Look at this. This is a case of mine. Look at the upper left. You can see this tissue that you showed. And there are many of these optic disc pits that have this tissue. And there are some papers reporting that this may be like a valve. Look at this. I'm doing the same as Faisal did. Look at this. Now I broke this. And look at the triamcinolone is entering in the subretinal space. And I'm convinced that the problem is a valve mechanism inside, inside the pit. And Thompson has published this many years ago. And let me now is your turn, Gracia, because I think you showed something similar to this. This is your
Carlos,
case.
do you drain? Because I've seen you.
Let me at the end of these cases we can comment on this if you like. Okay. Let's go.
Yeah.
Gracia, this is your case.
Yeah, I completely agree with what you said. It is necessary to remove the tissue inside the vitreous and the tissue inside the pit, but sometimes it's quite hard to remove
Absolutely.
it. And so you see, I do the same. Well, in this case, we have an optic pit, but also an inferior coloboma, but it doesn't matter. There is a detachment, a posterior detachment due to the optic pit, and the area above the coloboma is still attached. And I see here, I try with a small forceps. I tried with a 25 gauge forceps and with 27 to go inside. But you see, it is very hard inside. So I was afraid to damage the neural tissue. And so what I did, I decided to go bimanual. You see, I pulled quite hard, but it was impossible to remove it in a safe way. And so I decided to put twin lights inside, chandelier, to be able to use bimanual technique. And then you will see with 2 hands, it is a bit easier to remove it. I grasp it with a forceps and pull back with the scissor. And so in this way, gradually, it is possible to remove the tissue inside, and finally I got it. And usually it is not necessary to use bimanual technique, but in few cases you have to do it if you want to remove the tissue inside the pit.
My question is the same. It's wonderful result, Gracia. You don't you don't remove the subretinal fluid. You don't do a no.
I've never done it. No.
You never done it. Okay.
No, I've never done it.
Yeah, but it takes a long time to this fluid is so dense. It's a long time.
Yeah, it is chronic. So sometimes you can drain a little bit, as we have seen from the optic pit itself at the end of the surgery during the air fluid exchange. But more often you really have to wait months, sometimes even up to 1 year. The interesting thing is that when there is no exchange, when the pit, so to speak, is closed, then immediately the visual acuity goes up. So sometimes you have 20/20 visual acuity after 1 or 2 weeks or 1 month, while you still see subretinal fluids. And this is very curious in my opinion.
Great. Stratos, that's for you. What about the internal limited memory here? This is a case of mine. This is 20 years ago. 20 years ago. You see the OCT.
Definitely ILM pill.
You peel the ILM?
Yeah.
Okay.
No, I don't. Yeah, correct.
Okay, then it happened to me, and
How long did the patient posture?
No, he did perfect. No. This is a long-term. Schisis, and and maculopathy, but I remove the ILM, and the patient position face down, and the macular hole open, because in the upper OCT, the thing we are seeing is an open hole. You only have the internal limiting membrane there. Well, I reoperate the patient. Let me tell you one thing. Imagine this case: 2 optic pits, okay, and you have this superior retinal detachment here. You don't remove the subretinal fluid, because if you put gas in this eye, you are going to have all of these fluids in the macular area. None of you try to remove the subretinal fluid. In no case.
I'm quite afraid that when you make a hole somewhere, you can get a rhegmatogenous detachment after that. And
because
so
I always remove this fluid.
Always.
Through the optic pit? Through the optic pit?
No. Let me tell you one thing. And Grazia mentioned, and I tried to see it if we were able to drain from the pit. And in the first case of Faisal, it seemed that, was accumulating fluid when he was aspirating the pit. But, we all know that, some fluid comes down from the peripheral vitreous. Then it's very difficult. I tried to know it, but, it's very difficult to really say that you are, draining this. I don't know it. But for me,
in my opinion, from time to time, but it is one case out of 10, you can really see the drainage of a subretinal fluid. If you have a large neuroretinal detachment, you can really see that it flattens, and you see the fluid aspirating. But I think only in very particular cases you get it.
Yeah, but Grazia, it's so difficult because you are under air. Air is pushing up, then you are down. You don't see very well. You see fluid going down. It's very difficult to know if the detachment is shallowing. It's so difficult. I tried to know it, but I couldn't say it.
Excuse me, Carlos, this detachment is rhegmatogenous?
No. Only optic pit.
All right. So what is the problem if the fluid moves to submacular area?
Stays for 6 months, 8 months.
We know that optic pits delay to absorb the fluid without affecting the final visual acuity.
Well, some pits I've seen that may make, RPE disturbance in the central macula if you stay so much, and then at the end visual acuity is not that good. But no one of you mentioned about laser. I do laser in all my cases. I'm sorry.
I mentioned, Carlos.
You laser, Faisal. You laser. I saw it. You laser.
Carlos, we have a question about this one, if you allow. There is one comment also from Dr. Nazim Al-Hussein. He's a also vitreoretinal surgeon here in Dubai. He asking, did you consider to laser the temporal margin after the serous detachment has settled? If not, what is you thought? Vitreous is the only culprit. Is there any chance of recurrence in long term if inverted flap not done? So we need a comment about this one from all panelists, if there is.
Okay, Ahmed, Faisal.
I did in my second case that I showed. There was negative pressure, that what I saw, I explained. And I thought that the fluid was coming from the vitreous underneath the macula. That's why I did, temporal to the disc laser, endolaser at the end of the case. And there was a solid scar. But as every one of us, the real mechanism of, optic disc pit, it is debatable. Everyone has his own experience. I can explain to you what I do, but everyone is right, because I saw Grazia's cases, Carlos' cases, Stratos' cases. They all work out.
Yeah.
I think, in my opinion, humble opinion, maybe PVD is the key of success in most of optic pit cases.
Great.
Yeah, I agree. There is also a publication by Fernando Bottoni and another publication on the importance of vitreous detachment. To be honest, but I haven't done a study about this. To be honest, in the past, I always did laser all around the optic disc, not all around temporal part of the optic disc, not pit. But, and I stopped doing that because I did the ILM peeling and did the inverted ILM flap inside the pit and so on. But from time to time, I have a recurrence. So I think I will try to do again laser. I had the impression that it was better with laser.
Temporal side or 360 degrees?
No, temporal side. Temporal side.
180 degrees.
Yeah, 100, maybe even less than 180. It depends on the area where we're involved with the.
I go 180, Grazia.
180.
Yeah, 180. Yeah, for this.
You know what I did when I did laser, I used to put PFO inside because I was afraid. But if there is some fluids left in that area and you do laser, and you run the risk that you do too hard laser and damage the nerve fiber layer. Do you have experiences with it? Do you do without draining under air, or what do you do?
Yeah, I do it under air personally. I do under air. I am afraid that the PFO will finish underneath the macula.
You know, I think perfluorocarbon liquid has the advantage that, you know, makes the refrigeration of the retina less important than, you know, in many of these cases, you do laser and the retina is attached. Look at the first case up and left. I did laser, of course, and you say, oh my God, but you know, you don't have retinal detachment around the optic disc. But you know, you are creating a barrier with the laser. If you see up and right, you will see this white area. And this is the laser. This is the barrier that these patients they did. I remove. Let's move up a little bit more because we have so many cases. But
we have one question also, Carlos. If before we move to another things, there is one question from Ragbad Da Faisal. His question, I think yes. My question is, what possible cause of this condition, and to how much patient can restore central vision? So just to cover this one.
The question for me?
No, the name of the one who is asking also is Ragbad Faisal also.
I see. Anyone can
but
answer.
Also Faisal, you can comment. Yes, Dr. Faisal, yes.
Okay.
Anyone, it's for all panelists, yeah.
It's a congenital thing. I mean, patients are born with it. I mean, there is not a specific reason. I mean, this is it. And it depends about vision. I mean, it can from 20/20 to very poor vision. It depends if there is a previous CME or not. If there is no CME, there would be a very good vision recovery. If there is a CME, I mean, there would be a recovery, but not as good. If I answered the question, I don't know.
Yeah, thank you, Dr. Faisal. I think, yeah, it's very nice. So, but before we move, Dr. Carlos, can we just conclude what we can learn? I mean, now we are having this kind of disease and we are, it is rare, but it's still there. So if we can agree about certain points that can everybody do in these cases? I
think the most important point is you have to remove the posterior highlight. I think we agree on that first. Okay. The second is that, and Grazia mentioned this, and perhaps Stratos is not, you know, he doesn't agree, but you know, laser works. Faisal do the same. We may discuss about, you know, if we remove or not the fluid. I prefer to remove it. Other doctors prefer don't touch the subretinal space, but I think it shorten the evolution. But you know, again, it's a disease that we don't know many things, and don't start with, putting, the sclera inside the pit as a first surgery. I think you agree with that.
Yes.
You know, more simple is better.
Absolutely.
Okay.
Carlos,
how about, okay, Carlos?
One question, please. What needle used to drain? Was it the needle 41?
Oh, no, I use the 41. I bent it a little bit and I go in the subretinal space. I don't remove all the fluid, but I remove a large part. If you put perfluorocarbon liquid, as Grazia mentioned, you push the bubble in the inferior part, you tilt the eye a little bit down, and then the fluid is pushed a little bit up. And then you go there and then you aspirate the fluid and do laser. We're talking about the arcades. It's a small. If there is subretinal fluid, no schisis. With the schisis, it's totally different. Yeah. Because of that, I show different kind of, schisis, foveal detachment, retinal detachment. Because of this, I put different cases.
So for schisis, do you do ILM, foveal sparing ILM?
Me? No. I don't see the ILM. I don't understand. I haven't seen, why. Some cases I do the nasal side, yes. But this is very long to explain this because it's very long. But, let me ask you this case. This is very similar, but more complex. This is an amblyopic eye, very bad vision is a 9-year-old boy, girl, excuse me, with this coloboma. And if you look at carefully, macro hole. My question to you is, what do you do in this case?
Can you show Carlos?
We cannot see the.
Can you share the screen again?
Oh, excuse me. It's not share. Oh, excuse me. Oh, excuse me. Oh, I change it. Screen share. And here. You see it now?
Yeah.
Yes.
Perfect. Look at this, macro hole. Then, the distraction, and Grazia, what would you do in this case?
Oh, it is, but there is also an optic bit because
this is a coloboma, this is a big coloboma.
Oh, it is a big coloboma.
And very irregular, wall here.
In shape and probably long-lasting retinal detachment, maybe supraretinal strength underneath.
No. This is the vitreous. I will show you now.
Oh, only the vitreous. Okay. No, I would do a vitrectomy and inverted ILM flap over maybe the upper side over the hole. Remove all the vitreous.
Okay. I can't see you. I'm so sorry because Faisal?
Yes, of course. I would do vitrectomy as well. But if it's a little boy or little girl, there is no PVD, and you have to create PVD in such case. And definitely, I would maybe if there is a chance to make drainage, but I'll do it slowly through the macular hole, not with high pressure. Then I would, invert the ILM flap.
Okay, Ahmed.
I would do the same. I would do a vitrectomy, create PVD and ILM flap, but I would extend the ILM. So I usually do multiple ILM flaps, and I would extend the ILM to prevent any epiretinal membrane to develop later on.
Okay, Stratos?
It's a detachment, but not ergomatogenous. It's because of the coloboma,
sure. There's a macro hole there. There's a macro hole here.
And the macular hole.
Yeah.
All right. Okay.
Let me show you. Let me show you.
This is the macular hole. All right.
Yes.
Okay.
Yes. Then, the problem of these cases is that it's so irregular, the area where the macula is. So a very irregular wall, then it's not a normal case. Then I aspirated, I tried to do this inverted ILM flap, to put it there, but was so difficult to maintain the flap there. And at the end I did laser around and, at the end, I put this, and let me show you. I did 360, a stupid thing, forget it, because there was no break in the periphery. But, at the end, it ended like this, 2400 vision, the eye was calm, it was perfect, all the retina was attached. But, only I wanted to show this irregular part of this coloboma. These are very difficult. In some cases, you cannot see the hole.
That was before of the era of autologous retina graft on the macular
Yeah.
hole. Right?
Well, I was asking you because I wanted to know if someone of you would treat this with an autologous retinal graft, but I didn't do it. I didn't do it, and I did before cases of retinal graft, but that was so irregular that at the end I decided not to do. Look at this. Let me share with you this case. I operated on this boy in 1999, and was a retinal detachment, high myop, amblyopic eye, 3 breaks or 4 breaks. This is the draw of the surgical procedure. In 2017, the patient said, okay, I think I have lost vision, 20/125 and macro hole. My question is what to do. Faisal, this is your case. This is a macro hole with disguises. Faisal, explain your case.
Yeah, this is 45 years old female lady. She was referred to me, I think, from Baghdad with macular hole. This case, I did it in 2013, I think. Yes, 2013. I looked to the date, and there was a schisis with epimacular membrane. Just run the video, please. Yes. You can see after creating PVD, removing the remnants of the posterior hyaloid, and you can see the kinnochore still in the macular hole. I leave it, so once I stain, there is no dye that goes inside, but then I remove the kinnochore from the macula. In this case, I was not really at that time doing inverted flap. Just what I did a large internal limiting membrane peeling. And
Faisal, this was endorsed in green, this?
No.
This is blue because the colors of the screen perhaps changes the color.
Maybe. No.
Yeah. Was blue.
I don't use indocyanine green. I don't use it.
Okay.
I never used it. And I enlarge it temporally. Very clear, very large flap. And
I was impressed. Faisal. You know why? Because it's so difficult to obtain such a big, only flaps so large with the forceps in a high myop. Normally it breaks many times, and I don't know, Grazia, is your opinion, but I was impressed.
I was lucky.
No, it's not. This is not a lucky thing. Any comment?
Professionals.
Yeah, he's
no,
a professional.
I agree with you. Usually in myopic eyes, it's very difficult to remove the ILM. Sometimes it's very difficult to find it, really. And then you have illumination problems because there is not too much pigment. And so you have reflection of the light. You need to turn down the intensity of the light. And indeed, it's really not easy. So Faisal was very lucky or very good, or a combination of both factors.
And this is 10 days after the surgery, really.
That's great.
10 days after the surgery, there was closure of the macular hole, and
No.
I was very happy.
Because let me tell to the audience, Faisal, this is a macular hole with schisis. Don't forget that. Yes. These holes, tend to be more difficult to be closed. I think we can agree on that, right?
Absolutely.
Yeah, absolutely.
And the result is, wonderful. Stratos, Ahmed, any comment about this? Do you agree with everything, or?
I would agree with you that it's really difficult to peel the ILM, it tears. And I would agree with Grazia that an additional difficulty on that is that the lack of RPE. You don't have the contrast to see the ILM. And I think it's the only reason that intraoperative OCT needs to be in the theater. For these cases, it's absolutely necessary to have an intraoperative OCT to guide you and to navigate to you how to peel the ILM.
I agree.
But in my experience, to be honest, the intraoperative OCT sometimes it doesn't have the right resolution, enough resolution, usually to guide you. Because the resolution is lower than the normal regular OCT, and then you have a staphyloma from time to time. This is the reason why it is difficult to get a good picture, a good resolution.
So that means that you have experience, you have tried that, right?
Yeah, I tried it. I don't have it usually, but I've tried it, and it is it is not so easy. It depends on how myopic the eyes.
So we are going to keep struggling, right?
Yeah.
So I think in such cases, staining and restaining as well sometimes can help, because sometimes I would lose grasp of the ILM. I would not be able to see it clearly, and I would really want to see how much and the extent of the peel that I did. And in such cases, I would rather do an inverted flap that would add to the success rate of such closure.
Absolutely.
But definitely, Dr. Faisal is.
What I said, I did it in 20,000.
I
did not do really restaining because I was sure that I
it's brilliant. You can see well, very well. So no need for restaining in such cases.
One question.
Let me one question to all of you.
I'm asking you, Carlos, one question regarding macular hole in high myopic. You are a master in macular buckling, just for the audience. When do you recommend to do macular buckling and not just ILM peeling?
Grazia is gonna be a happy woman now.
Yes.
I stop it to do macular buckling. Then,
oh really? Oh, glad to hear it.
I stop it. No. I'm very glad to have been doing this, because the things we know now, the case of Faisal, we didn't know it 10 years ago. And this is a very long history, but I close holes that previously have failed. Then now we know how's the vitreous. Now we know to stain 1, 2, 3 times, and now we know how to be sure that you make an inverted flap. We know many things now. Then we have the total retinal graft, but we'll speak about it. Let's continue now. Ahmed, you send me a big macro. No, it's not a high myo, but it's a big macro hole. And then explain out your case.
So this is a 59-year-old female. She came complaining of drop of vision in the right eye, and the vision is 2400, as if I remember, and the left eye was fine. So in such cases, I usually do combined phaco-vitrectomy, because eventually the cataract will progress anyway. And in such cases, we can run the video, Carlos, please.
Sure.
I start like Faisal, just with triamcinolone, just to stain the vitreous and create PVD. And then I use dual membrane blue in all cases, so I do not shift actually the stain. And in such case, I start using multiple inverted flap. There is actually not a good stain. Some areas are patchy because maybe there was still remnants of the vitreous, but with inverting the flap, you can see that you can get a very good image of the internal limiting membrane. It started temporarily, and I do multiple flaps. Maybe it is not shown here, but I do not reach to the edge of the macular hole, and then I invert and trim. And after this, I enlarge my peel outside of the area of the flap to extend it till the arcades to prevent any traction on the edges of the hole. Sometime, because in most of the cases they usually close very well without any recurrence or so. That's basically it. I'm not touching. I'm just on top of the fovea, just to make sure that the flap is on top of it.
Great.
And I think we can see the post-op image.
Absolutely, we can, absolutely. This is a nice picture, Ahmed. This is a full, all the lines are there. The retina seems fine and perfect. It's a wonderful result. Which dye did you use? Which dye?
It's a dual membrane blue from
dual membrane, trypan blue and brilliant blue. Okay.
Yeah.
Okay. Let me continue. Do you have any comment, Stratos, Grazia, Faisal? Any comment from this case?
No.
Great surgery.
Oh, interesting.
Perfect. Let's go. Let me ask you about this. Some holes, and Grazia is an expert in that. In high myopsy and no myopsy, you see this tissue over the hole. How you remove this? Because sometimes you go, you stain, you see nothing. Now staining is in a high myop, it's very difficult to grasp. You see this, the brights in the macro area, but you don't see blue. You stain once, twice, 3 times. How you remove this fluffy tissue that Grazia reported with Parolini and Haritoglu some years ago? How you try to do this? Because no staining. Nobody?
No, what I usually do, I try to start the peeling not too close to the macular hole itself. And so usually if you go peripheral enough, let me say in the midline between the fovea of the macular hole and the vascular arcade, you can grasp some ILM, real ILM. And then if you proceed with the peeling, at some time you get some fluffy tissue and you find the plane to lift it up.
Okay.
And
great.
This may be a trick.
No, this is perfect. Because sometimes, as you mentioned, if the stains outside of the macro area. Any more comment? Let me show you how to do it, because this is one of the main causes of failure in high myopes. Look at I use this. I don't have any interest. Look at the fluffy tissue that Grazia was explaining. Look at this. No staining. This is fluffy tissue. Now you re-stain and you see perfect. The internal limitation. The stains wonderful, but you have to remove this fluffy tissue to have a good staining. But my case, the patient denied to be operated. And, 2 years later, the macro hole was this, 1,353 microns. Grazia, how to solve this, your case?
But the vision remains the same, huh?
The vision remains the same, see, absolutely, remains the same. But now this is the case of Grazia with a big macro hole in a high myop. Grazia, yours.
Yeah, this was a recurrent macular hole. The ILM was already peeled, a young lady, and she wanted to have something done. She wanted the macular hole to be closed. So I thought, as the first surgery was done by a colleague and then referred to me, then I thought, let's check, maybe there is some ILM, because I had the impression that there was something somewhere to create a kind of flap or a transplanted ILM flap, but in fact there was nothing. So you see here, I tried to grasp here and there, because as we mentioned, sometimes it's not easy to see it. You don't see the staining. And then I even tried to stain under perfluorocarbon liquid. So you see there is an interface between PFO and the retina. And so with not sharp needle, I go and put some drops underneath, and you see how the blue remains there, very localized and concentrated, but nothing. There was really no ILM. And then I decided to do.
Let me comment one important thing. Thing. Now, you are, having the graft with the retina attached. Then it's so difficult this, and then I wanted to point this because it's so difficult, because with the the arm, the long arm, you can touch the cornea, but this is you're so talented, amazing.
No, I'm not talented.
Sure.
I will tell you a trick everybody can do. So you delimit it with laser, and then you just pick up a forceps and you grasp the retina, and you really you grasp the retina like you do for the ILM, but not so soft, a little bit harder. So you really lift up a little bit the retina, and you create a localized detachment, and then you can go underneath with a scissor and no problem at all, and you don't touch the choroid. Don't try to go underneath with a scissor without detaching a bit the retina. You see here, I'm trying to position, you see the flap of retina, and I do it under fluorocarbon liquid to prevent that it shifts from sides. In fact, I'm not sure if it is really important to have the retina in the right side, or if it changes anything if you put it upside down with photoreceptor in the inner part. But anyway, from the show and the OCT is much better if you have a photoreceptor at the right side. And you see in this case, the hole is perfectly closed. Personally, I'm convinced that this flap of retina is not working. It's working like a plug, but it has no function. But anyway, the patient, after 1 month, recovered 0.2 visual acuity from counting fingers. It's not too much, but as she is 40 or if even less than that, she is happy with our visual acuity, regained visual acuity, and he has the impression that there was some recovery of stabilization of the situation.
Great,
this is marvelous.
Let me continue with my case, because we are going to see many things, and at the end we discuss this. Okay. At the end, the patient had detached retina and a big macro hole. Then, Stratos, what do I have to do? That's your case.
Well, I had a case similar to you. He came originally with macular hole and retinal detachment. And I normally do, let's pause it, please, a little bit.
It's paused.
Yeah. So in the first case, I did extensive ILM and put gas inside in order to close the hole and to reattach the retina. Let's start now. But he came back with, again, retinal detachment, no ILM peel on the 2 edges. And you saw it was the bubble there. So I decided to go straight for the autologous retinal graft. I went it and I extended the ILM peel as much as I could during the second operation with a stain, and then laser under air. A little bit of air, and then I left the graft to slide on the macular hole, because the eye had the staphyloma and the fovea, it's on the lower part of the staphyloma. So gravity will do the job. I didn't want to manipulate the graft in order not to damage it. And I left the gravity to do its job. And this is the result a week after the operation. And then the vision, and this is at the end, almost 3 weeks after the operation, totally reattached. And the vision went up to 1/10. I think the graft works. As Grazia said, I don't believe that the graft takes part to the visual function, works mainly as a plug, and the vision improves in comparison with the size of the initial hole. So the smaller the hole, the better the vision. And I think the vision stays there. The problem, the good thing is that we need to fix the retinal detachment initially, and then the macular hole.
Perfect, Stratos. Let me show the last slide of this group. This is the patient at the end, and I did the same as Stratos. We do different. Because of this, I try to show you this in small seconds. the retina was detached. I didn't need to detach. I put the flap inside the hole. You know, Faisal is going to comment on this because he always is aware about the photoreceptors. Laser and the perfluorocarbon liquid, and at the end, the patient, you know, macro hole is closed, has silicone oil, and vision went to again 125. The same as you. I think that, you know, this is a plaque more than really a functional retina. Faisal, that's your turn. Comments on that, because you are not so, convinced of that technique.
Oh, no. I'm convinced that this works. But what I mean, I do the same. I mean, I just cut the retina at the edge of the retinal break whatsoever, anteriorly if there is a retinal detachment. I try not, to slice it over the surface of the retina. I just do it manually with two hands, one with the forceps, and I have another forceps in the other hand. I just push it downward over the macula, because there is no way that you can do it without damaging the photoreceptors and the RPA over the macula after the arcades.
Okay.
Or there is, big chance that you make damage to the photoreceptors and RPE. If there is no retinal detachment in that area, if the retina is attached, it's very difficult not to do any damage in that area.
Great. Ahmed, any comment on that?
I agree totally. I didn't do actually autologous retinal graft, but I would be inclined to do it whenever I had a recurrent large macular hole like this. But in smaller recurrent macular holes, I would, with good ILM peel before, I would try to do a free flap or ILM, and this works equally fine, but usually in smaller macular holes. But in such big and myopic macular hole, I would be inclined more to do autologous graft as well.
And we may agree that in this kind of case, the most important thing is to reattach the retina, to have the patient with, some function. Is that right for all of you?
Yeah,
Okay.
I completely agree. I wanted to add, I think there is also a question about it, amniotic membrane. Amniotic membrane is another tissue that you can use. There are, in my opinion, a couple of disadvantages. First of all, you have to, usually we don't have it in our OR, so we really have to order it in advance, and it is quite pricey. And second, it is a quite rigid material, and so it doesn't fit very well inside the hole. You need more manipulation than with retina, and so I think it is, I did it a couple of times, and then I switched to use retina plaque if necessary. If you can find somewhere some ILM, then it's very, very nice. But sometimes you really, in some reoperation, you really have no ILM left, and then you need to use
Great comment. Great point. Okay, let's continue.
Carlos, we have few questions before you move to the next.
Sure.
Okay, maybe one of them related to the first part. From dear Dr. Safwan Al-Bayati, he's having a question. What about temporal laser before pars plana vitrectomy?
Temporal laser? You mean
about the pit?
Yeah,
we are talking about the pit. Yeah,
optic piece. Is very. The effectivity of this is very poor. Why? Because you don't have it refrigerates the liquid that is under the inside the retina, refrigerates the laser. And the effectivity of this, in my hands, in my experience, is very poor. But if Safwan has tried it and works, in my experience, it works in few number of cases.
Is there any comment from any other one? Any other one want to comment about Dr. Safwan?
I completely agree with Carlos. I've done a couple of times, and I think it worked in one time. Because usually there is the traction of the vitreous is still there, and it's very difficult. I even tried with injecting a gas bubble, and position the patient, and then do the laser to make sure there was not too much fluid. But usually the gas bubble is not enough to detach the vitreous, so the traction is still there, and it is not a permanent result.
Yeah.
Any other opinion? Is there any other opinion? Not same opinion? Something different?
I mean, you have to use very heavy laser in order to have a good take. I mean, I was using it in the, I think 89, something like that in Ottawa in Canada. And it almost never worked, almost never worked.
Stratus or Dr. Ahmed, any other comments about Dr. Safwan?
No, I agree with Carlos. I don't think I used to do it a long time back, just a temporal laser red, but it needs to be heavy, and it is not working in all the cases. It's very seldom that it really formed the scar that would close this optic pit and decrease the fluid. So I think now the treatment is vitrectomy and ILM.
Before we move to another questions from Dr. Nadeem and other colleagues, on behalf of you and all ophthalmologists, I want to actually to pass the message to Dr. Safwan and condolence him about his loss of his father yesterday. So just this is on behalf of all ophthalmologists. We are sorry for your loss, Dr. Safwan. Okay. Next question is Dr. Nadeem. He said, what I have learned, and when I used to use diluted ICG dye before 2008 with BFO over the macular hole, peeling of ILM was easier and staining better. Any opinion on this? This is what he is saying about the ICG. Then he said, since 2008, I have been using BBG, but I still love diluted ICG dye. So if there is any comment about this one, we can go fast.
It is written that, you know, the ICG makes the internal limiting membrane more rigid, and then you see better the ILM, and it's more rigid, and then it's easier to obtain the large flaps that Faisal showed, the impressive flaps. You know, I don't have these flaps in high myopes, but you know, I think the ICG has this effect. I don't use it personally. I don't know you, but you know, I don't use it because of the toxicity and all of this stuff. You know.
I think there is one question, but I think Dr. Grazia or Dr. Grazia already answered from Barbara Dallas. If is any of you using amniotic membrane as a graft to insert in the subretinal space? I think if you want to comment again about this one, already you are. Dr. Grazia. Okay. We are having, there is a question also from Dr. Nazim. Retinal pigment epithelium atrophy following indocyanine green dye, assisted surgery for a serous macular detachment. He said here, what do you think about this one? There is like a study he is mentioning here, Nazim al-Hussein, Shubadra Jalali, Al-Kabrani, and another names actually published, and also Carlos about this.
The worst RP, no, it was not the worst, but one of the worst RP, you know, disturbance I saw in my life was ICG under the retina, so many years ago, because I abandoned in 2000 ICG, but I don't use it because of this.
Okay, I have no experience at all with ICG.
Me too.
Neither do I.
Okay, one question is here, what about macular hole with retinal, I think pigmentosa, retinitis pigmentosa?
It is an important question, because sometimes you have a macular hole in retinitis pigmentosa, but when you do ILM peeling in retinitis pigmentosa, usually it ends up with a damage of the neuroretina. So it depends on the situation. I usually tend not to treat it, because in majority of cases they do have a relatively low visual acuity anyway. I've done, to be honest, with a good success, a good recovery of visual acuity in one case of a patient with a pretty good visual acuity and then sudden loss of vision, and then he recovered quite good after the macular hole closure. But you really need to evaluate what the preoperative visual acuity was and the risk of surgery, the risk of ILM peeling, and discuss with the patient.
Fully agree. I have the same case, the same, absolutely. Mm-hmm.
What about phototoxicity, guys, in RP patients during surgery? Do you consider that as a major risk factor?
You know, the surgery
takes by light, or no, I don't think that light exposure is a major risk factor, to be honest. I think it's more of a manipulation and the ILM peeling that can damage, because you get the same problem if you do it for macular edema in retinitis pigmentosa, for example. It is very rarely an indication for surgery. Even if you see some macular puck or some epiretinal membrane and macular edema, usually it does not work very well, in my experience at least.
Is it different between a full thickness macular hole or partial thickness? I mean, I'm talking about retinitis pigmentosa still.
Yeah, I usually don't do surgery in a lamellar hole or pseudo hole or something like this. I only consider it in full thickness macular hole.
Okay, I think
in specific retinitis pigmentosa. In other patients, of course, I do also in lamellar hole, but not in retinitis pigmentosa.
Okay, Carlos, we can proceed. Yeah, I think
okay.
For the time being, we finished most of the questions.
Two questions in this case. Two questions. First, and I want your answer. First, do you do ILM sparring or you cross the fovea? No problem. You know, in the literature, you can find both ways. And second thing, you leave something in the eye at the end of the surgery after doing your vitrectomy. We're talking about the right eye, okay? The image in the left. Grazia. ILM sparring or not, what do you leave inside the eye?
Yeah. They are myopic eyes, I guess.
Yeah, sure.
Yeah. Yeah, always fovea sparing, because I'm really afraid of macular holes in these cases. Probably you don't need to put any tamponade, but I usually use air.
Perfect. Faisal.
I use air just in order to close these sclerotomies to make sure there is no leakage at the end of the case. But it's not necessary at all, I mean, to do a total exchange in air, just to make sure that you don't have post-operative leakage.
ILM sparring?
Yes.
ILM sparring. Stratos. ILM sparring gas or nothing?
ILM peel and nothing if I don't create a macular hole. If I create a macular hole, I put gas. But I do vitrectomy and PVD exists. There's no need to do PVD, but I peel ILM. And if I don't have a macular hole, I leave it as it is and absorbs by itself.
Perfect. Ahmed, ILM sparring and gas, or what do you do?
ILM sparing and gas, yeah. And there is retinal vitreous schisis. So what PVD is always questioned. So to stain with the triamcinolone and double stain again to make sure that you actually did a total PVD before going ahead and staining the ILM.
Let me show you my case. You know, I did, you know, because if you look at the literature, you will find that gas, you know, or no gas is, you know, it doesn't change anything. And in one paper says that, you know, if you put gas, be careful because you can have more complications. Look at my case is this, and this is surgery. I'm sorry for the quality because it's very poor. I don't know, the camera was, you know, in good setting. Look at this. I'm going from the periphery to the center, non-crossing the foveal area. I'm going to go faster, okay? Here, and I don't try to cross the foveal area. I fully agree. I cut it with low cutting rate and low aspiration, and I leave this. I leave this and nothing more. I don't try to go just to the fovea to peel the ILM. Okay, I leave it like this, and I put gas in the air, only air in the eye. Wonderful result. You know, there was one paper published that said that, you know, if you put air or gas in the eye, you will have, you know, a longer time schisis, and you will have a higher risk of macro hole. You know, I have two in 10 years, but, you know, always think about that you may have a macro hole after this. This patient didn't want to be operated again, but what would you do in this case? Grazia?
No, I would, Piero, you left the ILM not to the edge of the hole, but yeah, a real fovea sparing. So I just would peel up to the edge of the hole and do an inverted ILM flap.
No, but the ILM has been removed, except in the around the macro hole. But you know, you see in down.
But don't you think that it is enough?
Excuse me?
Don't you think it is enough what you left?
I think it was enough, but you know, now I don't see it now. You mean you go to the border and you put it inside the hole, okay?
Yeah, I just stain again. If this is the case, you...
I catch it. Okay, yeah. I got it. Faisal, you?
I would stain again, and I see where the ILM is, and I just, I mean, put it over the hole, or I put it inside the hole and go in gas again.
Great. Ahmed?
Yeah, exactly the same. If not, I would do a free flap from the periphery. Yeah.
Okay. Stratos?
What is the size of the macular hole? Are these three are the same or different?
No, it's the same case. It's the same case.
The same case, because the top one is smaller, the middle one it's larger, and the lower one it's again. What was the size of this?
No, look at this. Look at it. Let me explain you. In the top, this was described by Kuhn and Tano. When you have schisis, you know, the macro hole, you know, is not that big. But, you know, when the inner retina tends to go to a staphyloma, it opens. Okay. And the second row is 9 millimeters, 6 millimeters scan, and down is 9 millimeters scan. Because of this, you see that, you know, perhaps the staphyloma is more. This is a problem of the cirrus, that, you know, the proportional image is different in size and 9. Okay. But, you know, macro hole is around 700, something like this.
Okay. Well, I have tried in myopic macular holes also. I tend to do fluid gas exchange in the office, and ask the patient for a strict face down position for a week and maybe longer. And holes tend to close. I mean, I have nice OCTs to show you that holes sized 600, 700, after reposturing, they close. Right. And actually, I had a case which closed 3 years after the operation.
Wow, this is a miracle. This is a miracle.
This is a miracle. Excellent, and the vision improved. Honestly,
right.
That lady had in both eyes macular holes, the long-standing, and I did the operation the same time in both eyes. The fresh one closed, the second one didn't close, and the lady didn't want to face down again. So she denied, but then 3 years later, she said, let's try it, doctor, and the hole closed. Anyway, I will try the in-office push-pull fluid gas exchange, and if it will not close, I will go for ILM searching in the periphery to plug the hole.
Great. Then we agree perhaps, you know, ILM sparring would be more safe. And, you know, and perhaps we don't need gas to put in these kind of cases. We may agree in that?
Yeah.
I wouldn't know about whether gas would be the main problem causing this
one paper saying
macular hole. Yeah, I know, but
you know, it takes a long time to explain why. But you know, I think perhaps was the gas what happened, because there is no. I don't have any other explanation. Okay, but let's move. You have a patient with a retinal detachment and luxated lens. Okay, then what's your next move? Then Faisal, your second case, your third case. Let's go.
Yeah, this is a young boy that he came to see me. He had, you can see there is a valve inside the eye, glaucoma, cataract surgery before and luxated. He came to see me with severe hypotony and total retinal detachment. I started by reformation the globe by injecting BSS. Can you run the video, please? Yes. This is giant retinal tear, and this is the IOL that is luxated. Of course, you don't go and take the IOL right away. You have to free the IOL from all its attachments. And you have to stabilize the posterior ball before deciding to remove the luxated IOL. Here I remove the ILM under heavy liquids. And once I stabilize the retina, I remove the IOL.
Mm-hmm.
I remove the IOL. And here I continue my surgery. You can see here at the edge of the tear, a lot of PVR membranes. I try really to spare as much retina tissue as I can, and this is how I do it at the edge of the tear, just by manual, just like sailors. What they do with the rope, just take it from one hand to hand, peeling the PVR membrane from the edge. So the edge is free without cutting the retina. And then I decided to complete the retinotomy peri-anterior, of course, for 360 degrees. And this is how the patient did very well afterward, after removing the silicone oil.
Great case, Faisal, great case. Absolutely great case. Grazia, in a case like this, with PVR and so, so difficult case, would you do the same? Would you do other thing or whatever?
No, I think I would do a similar thing. Maybe I would have tried to free the IOL from the vitreous and to put it in front of the iris in the beginning, because I got the impression looking at the video that it was not easy to manipulate the retina, to work on the retina, leaving the IOL in that position, hanging down, and probably you could free it from the vitreous and put it in the anterior segment and then remove it later on when the vitrectomy was done.
Yeah, I did not show it in the case, but after removing the IOL, there was meiosis, and I had to put iris.
Absolutely, absolutely.
Usually, once you remove the IOL, there is meiosis. Yeah.
Great. Let's go in a case not that difficult, but Stratos sent me a case like this, and I made a slide for Stratos because perhaps some of you they don't know the lens where from the audience. I don't know. Then Stratos, this is the lens you are going to use. Explain us what's this.
This is a brilliant idea of Carlos Scarlevale. He designed this lens, which is perfectly made for a scleral fixation intraocular lens. He has these two plugs from each side, which goes in the middle in intrascleral, and he has these two flaps from each side that prevents tilting of the lens, and also has this big optic that sits behind the pupil and looks like an ordinary posterior chamber intraocular lens. It's a brilliant idea. Once I saw it 3 years ago, I immediately adopted the technique and I started to use it. And I found it brilliant because it has eliminated my complications for the scleral fixated IOL, the previous scleral fixated IOL techniques, which was slippage of the haptic or tilting of the haptic. So what makes this lens ideal, I can show you in the video if you like Carlos to start it. It's quite minimal. You create from each side an incision in 2 pockets. And once you create that at 3 and 9 position o'clock, And once you create that, you put in the other 2 trocars and you go for the vitrectomy. This gentleman had an ERM, so I peeled the ERM. And then I went in and fished the lens, brought it into the anterior chamber, cut it in the middle, halfway, and then with the Pacman techniques, I took it out. And once the lens is out, I placed in the cartridge the Carle-Valle intraocular lens, injected into the eye. It's nice to have these specially made Dorks forceps which are curved in order to grab the first plug. And once you grab it, you pull it out from the nasal side. And then you feed the other forceps from the other side and you pull it out. And finally, you place the 2 ears of the plugs into the scleral pockets that you have created. And that's it. And what also is the most important thing is that you don't scared to make a scleral indentation at the end of the operation, which I was very afraid to do it before, preventing the slippage of the haptic of the intraocular lens. Now, I'm sure that these 2 plugs are so steady and stable. So in every case, I do a scleral indentation at the end. And also I have eliminated the complication of postoperative retinal detachment.
Great case, Stratos. Great case, great technique, wonderful mate. Perfect. Ahmed, Grazia, that's for you. That's a case. Grazia, you know this case because you saw it before. But you know what could you do in this case? You have a myope patient with a macro hole, and then you perform your vitrectomy. It's wonderful. You are fine, and everything is fine. And suddenly, the lens goes down. That's your. What do you do in this case? Grazia.
Nice moment. You ask for help.
Is there anybody there?
Is there anybody there? No, it's not a nice moment. I can believe it. Now I think you really need to remove this kind of lens.
I suture. In this case, I suture to the iris. It's fine, but these are lenses not that easy to be.
But this is very interesting because if you can manage to avoid the removal of the lens and the capsular bag and whatever, this is great. I really like to see how you
No. I'm not showing you this. I will show you another.
You're not going to show it.
No. I showed it in Barcelona. You don't remember.
Yeah.
This is the case. We started. It's on only one eye, and I decided in this case, some myope patient, I decided to anchor this to the iris. This is not a perfect technique, but at the end works. The patient is fine. It's 0.3, 0.4 vision. Was a low vision before. Then it's a Down syndrome, and it's fine. This is another way to do it. At the end, you prefer the technique you master the most, and this is one technique you have to know. Let me ask you. We change the topic. Look at this. High myope, 35.57 and 35 point something. Okay, left eye 20/32, right eye 20/40. Okay, would you operate at this moment in any of these eyes or no? The patient has not noticed anything, and she says, "I'm a high myope. I know that I don't see very well, and nothing." Any one of you would operate this?
No.
No, then but then
is the vision dropping? Is the vision dropping, or is it always the same? Always the same.
No, the same. No, I wanted to show you this because in lamellar macro, we can say lamellar macro hole to this, although it's not the typical. But in high myopes may evolve to full thickness macro holes, and we have to know that because left eye at the end they went to macro hole. Then would you operate on this eye?
Yeah. Yeah.
Yes.
Yeah.
But let me show you something that I learned, you know, all of these years. We have to look at the optic nerve, because many of these myopes have glaucoma. And then now it was only for the young people. When you see a high myop, even if it has a macular hole, it's very important that you look the optic nerve and the pressure, and to be sure that the patient has, you know, not so bad, visual field, because you know the phenomenon that you operate on them and then the vision drops down. Fortunately, it was not the case. We could, you know, close the macular hole in the left eye. Now, the right eye, would you operate on that eye? Is a 20/40 vision? This is stable.
20/40 stable, or
This is stable. This is stable.
Yeah. I would have said no, but you show us that it can improve.
Yeah, no, because the other was macular hole.
Oh, that was the other eye. I
This
thought
is
it was the
laminar
pre-op
macular
and
hole,
post-op.
and I didn't operate on the right eye.
No, stable, and I would not operate.
Absolutely.
I thought it was the pre-op and post-op
Yeah,
visual
absolutely.
minorities is the right on left eye. Okay. No, I agree.
Good topic now. Subretinal hemorrhage, age-related macular degeneration patients. Okay, look at this.
Carlos,
right eye.
Carlos, can we stop in this?
Sure.
Please?
Sure.
And we have few questions before we move, and maybe we can also finalize these things later in another webinars and divide it into 2 parts. What do you think?
Oh, yeah.
Because we are already 1.5 hours. We have a few questions, so we can answer it. Then if there is a time, we can go, because this one, I think it will take another 15 minutes if you start, right?
Okay.
Okay, there is a question from also dear Dr. Safwan. He is asking, he is putting BFO on the macular hole can prevent retinal pigment epithelium from trapping blue toxicity when doing ILM peeling. And the other question, is trapping blue toxic to the macular retinal pigment epithelium?
I start. You know, yes. Perfluorocarbon liquid helps to avoid the contact of the RPE with the dye. It can help. And I think that trypan blue, it's my personal opinion, that trypan blue is more toxic than only beryllium blue. Then when I have macular holes, I only use, you know, a beryllium blue.
Okay. Is there any other comments, or it will be the same from other panelists?
Same.
Okay. We have here also one question. Your experience in the treatment of macular edema following retinitis pigmentosa. I think it's something a little bit different than what we are talking, but it's also related to retinitis pigmentosa.
Grazia, you mentioned.
As I said, I think that in the majority of patients with retinitis pigmentosa, surgery doesn't help, even if you see some epiretinal tissue, epiretinal membrane, unless there is a really significant traction. But it is an exception, because usually macular edema is correlated with a disease, with a retinal degeneration. And so I don't think surgery in the vast majority of cases is helpful in these cases.
There is a question from Dr. Qasim. He is talking about drop IOL. And this is the only one eye, and previous already have retinal detachment surgery, vision with spectacles 0.9. Would you leave it alone or remove?
Stratos.
The lens has to be removed. Never leave a floating lens into the vitreous cavity. I mean, it's going to harm it. There is a paper published back in, I think, 1987 or 88, saying that the 30% of the dislocated floating lenses into the vitreous create retinal detachment. 30%, it's a big number. So you have to replace it.
Okay. Is there any other opinion?
I could manage the lens. I never leave the lens moving inside the eye if it's a retinal detachment, but you can have other problems. And I think you have to do something, remove it or suture or change. Change is difficult because you cannot calculate. For example, the lens of Stratos, the Carnevale lens, you need to measure, and a retinal detachment is so difficult. Then it depends on the situation, but I wouldn't leave a lens floating there, never.
Maybe the last question. Okay. Yes, Doctor, sorry.
No, I agree. I will remove it.
Okay. There is one more question. Is having a serous retinal detachment, is ILM peeling versus burst planar vitrectomy the answer? No initial conservative measure like laser. If yes, when do you go for surgery?
Repeat again. I lost it. I missed it. I'm sorry. I missed
well,
it.
I think this one is talking about the whole what we are talking about previously. Having a serous retinal detachment.
Serous.
Okay? Yeah. So is ILM peeling versus burst planar vitrectomy the answer?
No.
There is no treatment for the serous retinal detachment for vitrectomy.
Okay, that
is not for vitrectomy.
No initial measure like laser.
So it is not a problem that would be treated by. It is not a surgical issue to be addressed with vitrectomy. So if we are talking about diabetic macular edema or cystoid macular edema for any reason, so you can treat it medically or injections or laser even if although I am not really fond of that, but there is no surgical treatment for that.
Just an announcement for all the panelists and also for our speakers. We are already putting the link. If someone just to get the certificate of attendance, it is found in the chat. Just you have to click and put your email, and you will get immediately for those that are interested to get a certificate. I think we finish. If you want to have another 5 to 10 minutes to cover the last topic, Dr. Carlos, or we can keep it.
Let me the second case of Ahmed, he's a diabetic patient. Can you explain about this? Because I have two questions. Can you explain about this, Ahmed?
Yeah, this is a young diabetic patient. She had the traction rhegmatogenous retinal detachment in the left eye and in the right eye traction retinal detachment involving the fovea. And in such case, I usually use bimanual technique, and I inject initially anti-VEGF a couple of days to 3 days maximum before surgery, and basically to remove the membrane, either in block or by segmentation, whatever I would be able to do. And usually I start with a vitrectomy peripheral, trying to do the PVD. And in certain cases, I would do from central to peripheral. In this case, there was actually extensive traction on the fovea. And we can see here the ILM peeling. I tried to make a foveal sparing actually ILM peel because it was so protruded and elevated, but by the end I peeled it all because I felt there was some element of traction still on the fovea itself. I try as much to extend the ILM peel, and that's basically it.
We lost it. We miss you.
You did?
Your voice.
I'm sorry about that.
Okay.
Can you hear me now?
Yeah, yes.
I'm so sorry. So I was trying to do sparing of the foveal ILM peel, and just because there was extensive traction on the fovea. The fovea was herniated a little bit. So and that's it basically. And I put gas and complete the PRP till the periphery, and that's it.
Perfect. Mohammed, I think I have one case for asking questions, but I think we can end here because it's so late. If you want to say bye to everybody. For my part, it has been a pleasure to have you here. It has been an honor to have these guys here. So experienced surgeons, Mohammed, has been a pleasure. Your kind invitation, and have a good day.
Thank you very much, Carlos. Actually, we are already on the time. It's very good. But also, I think we already just crossed half of what we prepared. So we can have another sessions in the future to continue what we already prepared. It will be a great, and it was very, very nice. And I'd like to thank you, all of you, Dr. Carlos, Ahmed, Dr. Grazia, and Dr. Stratos, Dr. Faisal, for your effort and for having this a very high level scientific meetings. Really appreciate. And I think most of the people, they are learn a lot. And me personally, even I'm not a veterinary surgeon, maybe medical retina, but I learn a lot about what you are saying. And very nice. I think we are having many veterinary surgeons, they attend this meeting. We reach about 130 and above only here in the Zoom. I didn't anticipate actually to have this number. We have more than that in Facebook and YouTube, and it was very nice. And I'd like to thank you all. I'd like also to pass my message and thanks for all participants. They attend this meeting. Also, I'd like to thank also the sponsoring company, Alimera, for sponsor this meeting. Very thanks to Balqis for her effort. And special also thanks to our management events, Marvision, for being with us and supporting us. And I would like also to tell all the panelists, they can get the certificate without sending this. Don't send your email. Just go and click the link and just apply, and you will receive a certificate immediately. Thank you very much, and we hope to see you inshallah in future, and we will arrange another meetings to continue this interesting meeting. Thanks a lot and goodbye. Is there anyone, just Carlos, and anyone to say something?
Guys, thank you very much for coming, and
thank you very much.
I really enjoy your presence and your discussions. Perfect. Thank you very much.
Thank you so much. Have a nice weekend.
Thank you.
Thank you very
You
much.
too all.
Bye, everybody. Bye-bye. Nice weekend.
Bye-bye.
Bye.
Bye.